Yeah.
Amazing. Perfect. Thank you so much. Thanks very much for having me. I was given this title, I assume by Julia, Early Days Modeling for New Things, which was nice and broad, and I was going to change it, but then I thought no, because I once saw Julia give a talk that was just called Jumpy and Wavy, and I was like, I didn't even know what it was going to be on, but it's brilliant. So I'm trying to head towards that kind of thing where you don't quite know what you're going to get. But what we're going to do here is we're going to actually go back to the very early days of modeling, and I'm going to talk about essentially January to March of 2020, which was a bit of a weird thing to think about when putting this together, because it was so long ago now. So I'm first going to talk about, as Matt brought up, as modelers, we're very, very interested in data. But at the very, very beginning, there was so little data. There were some official reports, but it was really, at that time, most of them were in China and then gradually in other countries. And having the capacity to have translation and contextualization of those data sources was absolutely critical. So finding people that understood the public health landscape as well as the public health actors in those places and help to bring that information, bring their expertise about understanding those data and where to find it, honestly, was really critical. At the time, there were lots of news reports and social media from a range of countries, which had the same caveat as above. These were data sources that a lot of us hadn't really worked with before. But news reports not only provided case data, but also included a lot of metadata and non-case data, like data on interventions. So, we might hear that, a lockdown has been put in place, or people or transport sector is shut down. But then if you can go to the local media or the social media in that area, you can find out a lot about adherence and a lot about how these are being implemented on a local level, which I think was really, really important early on, especially when you're trying to understand the growth of the epidemic in Wuhan and in other Chinese cities. There was also started to be using a lot of novel data sets. For example, Baidu, I don't know if you remember, is movement between places, a publicly available data set. Well, it's usually publicly available over the Lunar New Year. And so getting to grips with these new data sets became really, really critical in the very early stages. And as we know, dealing with data, the first thing you have to do is understand it. And that means a lot of time probing, understanding, seeing where the data has come from. Because all of these different data sets were collected differently, which means they're subject to different biases, subject to different underreporting and uncertainty. And so if you're going to include some of these data sets in your models, you have to think very carefully about how they're collected, whether this is passive surveillance, active surveillance, what's going on with case finding, what's going on with the interventions. So that's critical. The volume of these data sets also increased rapidly. So there was very little early on, and then gradually, especially as you start to include news reports, social media and things like that, the volume just increased unbelievably. And this is where crowdsourcing and open data, I think, really became important, and I think and hope will remain important. So these public sharing of collated data with traceability. So a lot of the data was shared on GitHub or on other websites where it keeps a record of all the changes and where all the data has come from. Absolutely critical, because not only does this mean traceability, so you can reference your data set and use it again in the future, but it also means you can give credit. Not a huge amount, but you can give credit to the people who have collected it, which I think is really important as we go forward with this kind of crowdsourcing and citizen science part of epidemic data. So the types of data that we needed initially, and Matt touched on this, was a lot of information on the natural history of infection. So this is the time from infection to a development of symptoms, time to hospitalization, time to death. And this was really lacking initially. And we were mostly getting hospitalization or death data, right, which is these very lagged indicators of what was going on. And we were really in need of some leading indicators. For example, evidence of infection or evidence of prior infections from serology. And so we were mostly getting disease, often very, very late, often severe cases. And that means in this, in the pyramid of severity, we really had very little understanding of how broad that pyramid was initially. And so when you start to see deaths and severe hospitalizations, you don't really have an understanding of the number of infections. And this meant initially there was not really enough power for stratification by the things that you really would want to, for example, by age and by location. But as I said, initially there was very little data and it wasn't very good. And then as time went on, the quality, thankfully, as well as the availability, increased. So early days modeling, what I'm going to talk about are these the unknowns and uncertainties that we faced in the first couple of months. And then I'm going to talk through some examples of work we did at the London School to address some of these questions. So there was a lot of, initially a lot of unknowns and uncertainty in the starting epidemic size. So the size of the spillover event, as well as how many cases had been seeded to new locations. And because of the uncertainty in the natural history parameters, we had a huge amount of unknowns and uncertainty in both the structure of the transmission models that we should be using, as well as every parameter of that transmission model. The incubation period, the recovery rate, how infectious people were, the timing of that infectiousness, all of it was somewhat up for debate. And then we had a lot of unknowns and uncertainty in the downstream output. So because we didn't understand necessarily the severity of the infection, if you do model infections, understanding how many of those are going to become reported cases, hospitalizations, and deaths, and how that might change from place to place and person to person. And all of these were important because they all affect how you might use models to understand the impact of interventions, which is a lot of the asks were coming to be, what should we do about this, So I'm going to talk a little about scenario type models, which generally don't have very much data in them, as well as later some inference models where we're trying to learn new things. So as I said, I'm just going to go through a couple of examples from work from London School, not that this wasn't going on elsewhere, but this is a study by Sam Abbott looking at the spillover event size in Wuhan, very early work. And why do we really care? Because the spillover size, you don't need to necessarily look at everything on this very nice figure, but the spillover size at the initial event really affects the estimates of the reproduction number in Wuhan. So if it's a big spillover event, this is what the figure is essentially saying. If it's a big spillover event, then in order to explain the epidemic we're seeing in Wuhan, you need a lower reproduction number. But if it's if it's a smaller spillover event, then the reproduction number is probably higher to have generated the epidemic that we're seeing. And one thing, as I mentioned, that there was uncertainty in both the structure of the model as well as the parameters. So Sam separated out MERS-like, SARS-like, and pre-intervention SARS-like, because at this point, there was a lot of uncertainty about what the parameters should be, whether this was going to be a repeat of SARS or what really the infection history was going to be. And so he compared these different assumptions there to see how that affected the reproduction number. And then, that's the epidemic in Wuhan. And then we were starting to see cases exported to other places. And what you're seeing here is answering the question, what is the range of epidemic sizes possible when you have one death reported in a country or a location? And this is work led by Thibaut Jeanbart. And what this really emphasizes, so the red line marks one death reported on the 1st of March, and then the blue shows the uncertainty in how many total number of cases were actually occurring in that place at the time. And so you can see it goes from a few hundred to basically 3,500, just to emphasize that there was so much uncertainty in those times, the distributions that we would expect, that you really couldn't tell very much about the progress of the epidemic from just seeing deaths. As we moved on a little bit, this is a study that looked at the epidemic size of the source location in Wuhan, looking at a range of data sources. So here, this one's covered up, but it says, what is the size of the epidemic in Wuhan that's consistent with the observed international dynamics? And so this is work led by Adam Kucharski. And what we're looking at on these lower plots, you don't need to look too deep to at all the detail. The black data are, the black points are data from a range of different sources. We've got onset dates of reported in Wuhan, and then we're also using data from repatriation flights where people were being tested on arrival, as well as new cases in Wuhan and international travel. And so the combining evidence from a range of data sources by fitting to them allows a lot more of different data sources to come to bear on your inference. And we use that to estimate the reproduction number in Wuhan based on a range of data, not just data that was being reported in Wuhan. And so I think that's a real strength of this approach to allow a range of different data sets, which all have their own issues, their own how they've been collected, in order to get a more robust inference about what's going on. So, and then we were asked, what can we do to prevent introduction, if anything? And so we then did some modeling work to look at interventions to prevent introduction. And this is specifically traveler screening, initially through thermal screening, either on departure or on arrival. And so the question was, can thermal screening prevent introduction of cases? The short answer was no. The long answer was no, it really can't. And so this piece of work was was in, I believe, January, when that was like a live question. And gradually the work was extended as there were other screening methods. But one thing to note here, so that we made a Shiny app, an interactive app showing then out of 100 infected travelers, how many would you detect at the outgoing airport, in the flight, or when they arrived. But you can see down at the bottom here, these are the distributions for the time to events for infection to onset of symptoms, onset of symptoms to severe, and infection to severe. And so the point was, we really didn't have a huge amount of information about what these values should be. But what we did is we included the capacity for the user to alter those distributions, both the mean and the shape of them if they wanted to, which allowed the analysis not just to exist once at the end of January, but allowed it to be updated as more information became available. And so I think that is a real strength of this work, and I'll describe later, that highlighting where you have uncertainty and putting the capability for not just yourselves but others to update it in real time as more information or their own assumptions changed, was really, really very, very important. So once it became clear that there was going to be introduction, was it possible to prevent establishment of transmission, for example, in the UK? And so the question was, can contact tracing and isolation of cases control outbreaks? And so we developed led by Joel Helliwell, a transmission model, branching process transmission model of contact tracing and isolation, with what we at the time thought was the natural history of infection. Somebody's infected, they show symptoms, and you have a delay to tracing them and finding their contacts, and everybody stays at home when you ask them to. And so using this model, we tried to answer the question, can contact tracing work? And our early estimates were, with a reproduction number of 2.5 under these particular assumptions, if you can find 80% of contacts within a certain amount of time, that will be beneficial. But we were very, very aware of the uncertainty in that natural history and in the seeding size. So what you can see here is, in the blue, is like the number of seeded cases that you're starting with, how long that delay is from the onset of symptoms to isolation, how much transmission is going on before symptoms. Our baseline assumption was 15%. But now maybe we think it's different. This was January. And what fraction of infections are subclinical, so aren't showing symptoms at all and won't be traced? Our baseline assumption was none, but that very much is something that probably, as things changed, got updated. And so we provided this code in an R package so that everything could be updated and changed. And I think that's really important, that it's not just us that was, it's not just people coming to us and saying, can you update the model? It's perfectly possible for other people to change the assumptions and update it in real time. So as time was going along, as we were getting more into February and early March, some of these key parameters of transmission, these uncertain, especially around the natural history, there were crucial papers being released, some epidemiological studies directly from China, and some secondary analyses and meta-analysis of publicly available data. These are just some examples, but there's many of them. And some of these epidemiological studies, very carefully done, very good work, are not massive. They don't need to be hundreds of thousands of people that we're now used to seeing COVID cases of 100,000 people. We're talking about a few hundred, sometimes less. Epidemiological studies really allowed a much better understanding of what these, the shape of the distribution, the means and the time delays that we should be expecting in our transmission models, and also the severity that we might be seeing by age. And so as these kind of data became available, that allowed transmission models, as these data became available and we were then more certain about these, that allowed your transmission models to be a bit more, it gives you a bit more power to estimate other things. So this is a study, there's way too much on this slide, don't worry about it. The point is that we fit it to a lot of different data sets, again, with a Bayesian evidence synthesis approach. The point here is that by firming up some of our understanding of the natural history, it allowed us then to understand, to try and make inference about more difficult parameters. For example, here, what assumptions about transmission to and from children are consistent with the observed data? And this study included, led by Nick Davies, included data from 6 different studies in an evidence synthesis approach, looking to estimate whether children were as susceptible to infection as adults. And then again, having better information on natural history allowed UK models to really get stuck into the question of what non-pharmaceutical interventions might be possible or needed for established epidemics. And this is a study, again, led by Nick Davies, but Matt showed the Warwick work, and there was work going on at Imperial and a range of other institutions as well. And this one tries to answer the question, when should lockdowns be implemented to maintain the epidemic under a healthcare threshold, which here is the dark line. And the point is, it triggered a lockdown every time the healthcare demand came up above a certain line. And this is kind of very, very detailed modeling that became possible once other uncertainties were a bit more concrete. Okay, so in conclusions, the early scenario modeling was really characterized by structural and parametric uncertainty, and many of the results, especially that we did, were provided with these caveats and were updated in real time and provided with the capability for other people to update them in real time. Inference models were fitted to diverse data sets quite often. I think this is a real strength, and where evidence synthesis is particularly valuable, especially when each single data set on its own is a little bit shaky. I think there's a large amount of insight gained from fairly limited data, especially on this natural history, but that citizen science, so this crowdsourcing and open data was absolutely crucial, and I think should be useful going forward. The public participation in the scientific process, I think, is fundamentally changed now. Just briefly acknowledge, as for everything, the Center for Mathematical Modeling of Infectious Disease COVID-19 working group. And we had in real time repository of papers, which is now kind of a historical archive, which I used to find out when all of this happened. So thanks very much.
Thank you very much. That was a real tour de force in terms of the work that you've done. I was really interested in what you were saying about the models being updated with data. Were these models regularly updated with behavioural data as we learned more? So I was thinking about your contact tracing example. How effective is contact tracing? And of course, as we moved through the pandemic, we learned that contact tracing varied in its effectiveness in terms of people's willingness to engage, willingness to be honest, and of course, people's willingness to self-isolate. Were those sorts of parameters put into the models as they evolved?
So I think not into that particular, not into this particular model. I believe Seb worked a lot with the contact tracing data, but as far as this kind of scenario work, that included quite a lot of behavioral data. The London School launched the COMIC surveys, which were happening every week. It was a contact survey asking people, you know, how many contacts they had, which gave a really clear, well, really good window into kind of adherence to lockdown and things like that. And that kind of information was fed back into these models. Yeah.
Thanks, Ros, lovely. So you mentioned the COMICs data that came out later, sort of when you were putting together that slide of the data early on. What studies would you suggest we think about for next time that we have ready to go? Or is it a case of using data and sort of having the repositories there to kind of get for the modeling? Oh,
you mean, so the first COMICs came out on the last day of March.
Okay.
I looked it up and I decided not to include it, decided that it wasn't early enough.
Yeah. Are there sort of thinking of that as an example of that we did do? Are there other things that you would do, like people to be doing next time?
That's a great question. I think this that's a great question. I think I found very interesting the trying to, you know, we would hear, oh, there's a lockdown happening in X place or Y place. I think the looking at news sources and social media to find out about adherence, and using other, you know, data sets around to understand adherence, I think it's really important because, you know, if you just take it as read that there's a lockdown here and a lockdown there, they're not necessarily the same. And it has a big impact on, you know, what you might expect for the growth rate in those places. So that kind of contextualization and using other data sets to understand what an intervention means, I think it's important.
Slightly linked to the previous question, but in terms of getting these key parameters as accurately as possible for the next pandemic in a faster way that might be potentially more reliable than relying on these broader sources that you've used. How robust do you think our plans currently are in the UK and elsewhere to get accurate parameters quickly next time?
Oh, I don't know about our current plans. Do you know about our current? I don't know about our current plans. But what I would say is that a lot of that information about the natural history came from, you know, very classical, very good epidemiology of the first few hundred cases in a place. And I think that's like historically been an extremely good way of, and the UK has excellent epidemiologists. So, but I don't know about future plans here or other places, unfortunately. Thanks.